Is the lighting okay?
Yeah, that's okay. It's looking good. So we are on Facebook already. I'm just checking if we are on YouTube. Yeah, okay. So let us get started. We do a quick introduction. Good evening, everyone. Thank you for joining this evening to talk about how lupus affects young adults and pregnancy. We are here with Dr. Manish Dugar, who is a senior consultant rheumatologist at Apollo Hospitals, Jubilee Hills, Hyderabad. And this webinar is supported by Biocon Biologics. Quick introduction for those of you who don't know us. I am Aparna Mittal. I'm the founder of Patients Engage. And Patients Engage believes that if patients and their family caregivers are better informed about their condition and how to manage that condition, then they will interact and engage with their own health better, as well as feel empowered to make informed decisions and make right choices. So as I said, this is the third in the series. We had done Understanding Lupus with Dr. Nilesh Nolka as our first, and you can find the recordings on our YouTube channel. We've done Managing Lupus Complications with Dr. Pradeep Kumar Sarma from Guwahati. And today we have with us Dr. Manish Dugar. He's done his medical degree and medicine training from the prestigious Christian Medical College, CMC Vellore, and he's done his rheumatology training from Australia, and he was awarded the Fellow of Royal Australasian College of Physicians in 2010. Since then, he's been a consultant rheumatologist at Apollo Hospital in Hyderabad, Jubilee Hills, and he has a rich experience in treating various rheumatological conditions, especially lupus. As always, a reminder to our audience that the information here is not to be treated as a specific medical consultation. So, doctor cannot answer your specific questions on treatment choices, etc., but generic questions will be addressed. And you can always reach the doctor after over the next few days through the Apollo Hospital website. This session is being recorded, and if you're logged into Zoom, you can post the questions on the Q&A. And if you're watching us on Facebook or YouTube, you can post them on the live feed and we will pick it up during the session. And you can always write to us at editor@patientsengage.com to give us any feedback or share your experience. And as always, you can find us on social media pages. We are on Instagram, Facebook, Twitter, and YouTube. So I will stop sharing, and we have a lot to cover. So let's get started. And thank you once again, the audience, for spending your Sunday evening understanding your health better. And thank you, doctor, for taking the time on a Sunday to address these questions. So the first question really starts with what is the typical age? Let's focus on lupus and young adults first. And what is the typical age when lupus starts, and is it typically the same for men and women?
So thank you, Aparna, for those kind words of introduction. And the question that you have asked is quite pertinent. The problem of lupus can start anywhere from the teenage years, so starting from 14 or 15 years, and can affect the patient up to their childbearing age, so around 35 to 40 years. Now, this condition is 9 times more common in women than in men. The age of onset in men and women is equally the same. And very rarely, after the age of 40, 45 also, patients can develop lupus. But the manifestations, the symptoms are a little different when they get it at a younger age. So as such, the disease only happens after the teenage years start. But younger patients and older patients are a rarity and not very common.
Right, right. And, you said that 9 out of 10 cases of lupus affect women. So how does it typically affect their quality of life based on your experience? What are the main challenges they face? And yeah.
So the biggest challenge that patients with lupus face is the delay in diagnosis. The way lupus presents is manifold. It has multiple symptoms, affects multiple organs. So by the time they reach a diagnosis, a good few months and even a few years may have gone before they are diagnosed. So
Right.
if the symptom is involving a particular organ, let's say, involves the joints, then their mobility can get affected. If it involves their skin and causes rashes, then obviously their self-confidence, their personality, those things get affected. And if they have a major organ involvement, which is the kidneys or the heart or the lungs, then there could be a threat to their life. So as a rheumatologist, what we tend to do is see the patient and then classify: do they have a mild disease, do they have a moderate disease, or they have a severe disease, and then go on to offer treatment accordingly.
Right. And you said that it could be mild, it could be moderate, it could be severe. What are some of the symptoms that, first of all, what are the symptoms that they're seen when it's mild? And, when do these symptoms start to affect their lifestyle?
So, because lupus is a chronic condition and it is most of the time insidious in onset, so it may take a few weeks or a few months to show its signs. Most patients initially may have a little bit of a flu-like symptoms where they may have low-grade fever, they may have some arthralgias, joint pains, muscle pains, and progressively over time then develop other things like a rash on the face, which is typically a butterfly-shaped rash on the nose and the cheeks. They may develop some weight loss. They may develop joint pains, swelling in the joints, early morning stiffness, and then, if more severe, have high blood pressure, swelling in the legs, and so on. So
Right.
initially, it may be that they are not able to function as well as how they were earlier doing. So they may lag in their school homework or their jobs. They might take more sick days. And as the disease progresses, they then tend to seek help and then get diagnosed either early or late. So definitely the quality of life is affected. And the earlier we diagnose, the earlier we treat them, they are back on track and go back to their usual routine.
So, if they are diagnosed early or even in moderate stage, can they get back to a you know, reasonably productive and functional life with treatment?
As if you look at multiple diseases which have chronic course,
Hmm.
whenever the disease is mild, the medications tend to work better, because if the disease is mild, we are able to control it faster.
Right.
If the disease is severe, we have to use more medicines, and control also takes a longer time.
Hmm.
So our focus as rheumatologists would be to make the patients aware as to, if these symptoms are there and they are persisting for 6 weeks, 12 weeks, we are not reaching a diagnosis, then we need to look at an autoimmune cause for the symptoms of the patients. Now, if
Right.
the patient has a mild disease, then we may use simple medicines to control it. But if the patient has moderate or severe disease, then they may need hospitalization, they may need injections, and more specialized treatment to control the disease. Now,
Right.
what treatment options we had in the 1980s and 1990s, and now it's the 2021, the treatment also has changed dramatically. Our confidence has changed. The drugs that are available are much better than what we had earlier. So definitely the patients, once they are on track, they have a diagnosis, they have a risk assessment, and they are on treatment, within a period of, let's say, 6 to 12 weeks, most of them show a good response and they are back to their normal activities. But they have to remember that this treatment is going to be long term, and there is no full stop that we can do after 3 months.
Yeah, I think this was one of the points we discussed before as well, and I think it's important to highlight is, often people think that, okay, I'm better now, and then they stop their medication. So if you can just quickly, reinforce the point on that, it'll be useful for the people watching.
Sure, sure. So again, if to put it in simple words, the medications that we give to treat lupus, or for that matter, any autoimmune disease, we are trying to control the overactivity of the immune system. Now, if the immune system is controlled, and the symptoms disappear and we stop the medicines, what is the outcome? The immune system again starts working overtime and the
Right.
symptoms come back. So if we continue the treatment and the response that the patient gives, accordingly we reduce the medicines or adjust the medicines. And our aim is to give the least amount of medicines to the patient so that we can control the disease. So rather than putting them on some 7, 8, 10 medicines for the rest of their lives, if they are better, the disease is controlled. Some of the patients might be just on a couple of medicines to control their disease. So it's like having this medicine to control your disease and having a good quality of life. That's the trade-off that they have to do. I'm going
Right.
to take a couple of medicines and I'm going to lead a normal life, or I'm going to stop them and I might land up in trouble in the next 6 to 12 months.
Right.
The other thing is that the medicines also have an effect on the body for some time. So patients tend to believe that I stopped the medicine on Sunday and Monday, Tuesday, Wednesday, I was fine. From Thursday, I started having problem, or I stopped it in March and I was okay till August.
Right.
So that they have to understand is that some patients, the problems might start in a few weeks. In some patients, it might be 6 months. So we need to, that's why, continue the medicines in the bare minimum doses, whatever is required for the patient. Some patients
Right.
require a lot of medicines, some people require only a few medicines, which has
Right.
to be tailored to the individual.
Right. Right. One question that's come in, doctor, from the one of our audience is how to identify lupus. Is there any diagnostic tests available?
Okay. So there are some, typical presentations which will say that, okay, the possibility of lupus diagnosis is there. And the number one, is the age and the gender of the patient. So if it's a female patient who is having non-specific symptoms like fever, joint pains, maybe some rash on the face, oral ulcers, losing
Right.
weight, and it's been going on for 6 to 12 weeks, we need to think about an autoimmune condition. And the commonest in these patients would be a lupus if there is a lash. So for a rheumatologist, because the patient may have seen multiple doctors before coming to us, it could be their general physician, the internal medicine specialist, or the orthopedic, depending on what symptoms they have. So
Right.
we have the advantage of time where the disease has evolved over the last few weeks or months. It's like a like a portrait. If it's half finished, we don't know what it is. But maybe sometimes when we see the portrait, it's full and we can guess, okay, this is the problem of lupus which is going on.
Right.
Once a clinical diagnosis of lupus is suspected, there are tests which can be performed, which include a blood test. So the commonest test that we do to confirm the diagnosis is called the anti-nuclear antibody test, or the ANA test.
ANA test. Right.
And then we do something called the ANA profile or the ENA profile to confirm the further antibodies which are present. And along with this, we do some other tests looking at the hemoglobin, looking at the urine exam, looking at the creatinine, complements. These help us to basically assess how aggressive the disease is, how much it has affected the patient, and then plan the treatment. So
Right.
definitely the clues are there in the history and exam, and they are consolidated by the investigations and the clinical examination.
Okay. And in terms of because you said it affects young women, does it affect their hormonal cycles, their menstrual cycles as well?
So the hormonal cycles are very, you can say, susceptible to a lot of things. Women may have noticed that the cycles become irregular because of emotional stress, because of physical stress, or because of some medications, or because of some diseases like thyroid. So lupus is no different. If the lupus disease per se is causing problems in the body, which could be fever, which could be anemia, where the hemoglobin is low, or problems with the significant organs like kidneys, they will notice that the periods are delayed or the periods don't come. Because
Right.
one way, it's the body's mechanism to conserve the blood if the cycles are delayed.
Right.
So that is probably an indirect, a cause of the disease rather than a direct cause. But again, that has to be looked at. We need to look at the other causes of period delay as well. But lupus, yes, indirectly it can cause hormonal disturbances.
Okay. Okay. And in terms of we talked of that you can get to a fairly normal lifestyle, but let's, because it's common questions that people have is, can I complete my studies? Can I work? What's been your experience with if you are on proper treatment and if you are following the protocols recommended, are people able to live and kind of study fully, or do they have challenges as well?
Yeah, yeah. So I've had patients who have come to me in their teenage years when they were going to school. I've had patients who've come to me in their late, 20s, early 20s when they were into their colleges where they were, doing their career, and also women who've come post getting married and, thinking of starting a family life.
Right.
So one thing is there that if the disease is mild, they quickly recover. So it's probably a few months of their active, productive life that they lose.
Right.
If the disease is aggressive, then there are a few patients of mine who had to lose 6 months or 1 year of their curriculum because they had to get their disease control. If somebody is having a fever every day, not able to get out of chair on their own, how can
Right.
you expect them to go to school?
Correct.
But I've had people who have finished their schools, gone to high school. Few of them have completed their studies in chartered accountancy. There were a few people who became doctors and finished their course. So with treatment, with the right advice, and with the right we can say the right time to treat the disease.
Right.
The delay in diagnosis and the delay in treatment does more harm than good. So, with good treatment and good follow up, good compliance with medications, most patients do generally well and they are back on track.
So just on that, right, because you talk of delay in diagnosis, and we see that as well in a lot of the experiences that people share. I know we've talked of the symptoms of rashes that are not understood. Is there how much time should they give, or if they've tried out talking to a GP or a dermatologist, at what stage, if their dermatologist doesn't refer them to a rheumatologist or their GP doesn't refer, should they be taking that initiative themselves? And if so, after, how long of trying different things?
So, if we have a disease which is, let's say, viral or infection or something which is maybe going to settle on its own, usually 6 weeks to 12 weeks is the time that it takes to settle on its own. So if we have an injury and there was a place which was hurting, we all notice that within 3 to 4 weeks, the injury heals, the site of pain becomes normal. But if the symptoms persist and they persist for more than 6 weeks, or you've
Right.
seen a couple of doctors where the diagnosis was not clear and there's no headway, then maybe looking at an autoimmune disease workup is a possibility. Now, there are a few instances which I would like to share. Is there are patients who've had problems and they have come to a rheumatologist and got better.
Hmm.
So they are the ones who are actually very good sometimes in picking up what's happening, and
Right.
then they refer their relatives to me, saying that, okay, I had this problem of joint pain, rashes, and this is what the doctor told me. You've had it for 1.5, 2 months. Why
Correct.
don't you go see this doctor?
Correct.
The second good thing that we have in India is that we can just walk up to any lab and tell them to do a test for me. Most of the time, a doctor's prescription may not be needed. I can walk up to a private lab and tell them I want this test. So there are a few instances where the patients have done the tests, come and seen me and shown me, okay, doctor, I did this test, it's come positive. Now what do I do?
Right.
And the last thing is, I have some educational material which is outside my room in the hospital, where I have highlighted a few diseases like psoriatic arthritis, rheumatoid, lupus, spondyloarthritis. These are 4 diseases where I have put some posters and I have put some simple, symptoms and some pictures. I'm quite surprised that, in a month, at least 5 to 10 patients will look at that and come and see me and tell me, doctor, I have that problem. Is it that? And honestly, sometimes it turns out. So
Correct.
patient awareness, talking to other relatives who might have, underwent this, gone through these problems, and sometimes maybe doing a blood test out of their own. But some patients do it, some patients don't.
Right, right. Yeah, so I think that's always a tricky one, right? Because on the one hand, we tell people don't Google and search for information, don't self-diagnose, but there are times where it is helpful to, I guess the point is it's worth kind of looking out for these symptoms and looking out for causes, but don't do the ultimate diagnosis,
Correct.
then go and see your doctor, right? And figure out what the treatment, the diagnosis and the treatment is. The
We
other thing that, sorry, go ahead.
Yeah, no, we can't stop anybody from Googling nowadays. So that's part of our life. What I
Right,
was trying to get across is that there is no harm in reading about your disease. There is no harm in Googling your symptoms. I don't mind that. But
right,
the interpretation of the test, the interpretation of the symptom, and the final diagnosis should be left to the doctor.
right, right.
Because if we do it on our own, it causes undue stress.
Correct,
Yeah.
correct.
And if the patient is desperate, not getting better, and for the satisfaction of the patient, if a test is performed and it shows a path ahead, then what is the problem? At
Exactly.
the end of the day, we want the patients to get better.
Yeah, yeah. And I think that's perfect, because that's exactly what we also say, that it is important as patients to, be aware of your own symptoms, your own body, and take action accordingly. So thank you for that. One question which we've received is on flares. Why do flares happen, and what can we do to prevent them?
So, a flare in simple terms is the disease has become worse. Now, the
Mm,
disease can become worse because of no reason. So,
mm,
the first reason is that there is no reason, it just goes up and down, so it has happened.
mm,
The second reason is there is a trigger. Now, what is the trigger? In lupus, the one of the known triggers is sun exposure. So, if
right.
there was a patient who went out on a 40-degree afternoon and had a lot of UVB radiation, or went to the beach and had a lot of sun exposure, and they had this disease earlier, or they had a tendency to develop this disease, they might see that the disease is getting worse, or the diagnosis has come to the forefront.
Right.
And they have developed some rashes on sun exposure, they have developed some joint pains, and they've developed some oral ulcers and things like that. The other trigger is occasionally viral infections. So
Right.
viral infections have a tendency to upset the balance of the immune system, and the immune system tries to fight these infections, and in that overactivity also tries to damage the joint. The fourth trigger is in lupus is pregnancy. So pregnancy can flare the disease or cause worsening of the disease, especially in patients who've not had their disease, which is well controlled.
Right.
So these are the four conditions. And again, as I have mentioned earlier, depending on the organ which is involved, depending on the amount of disease flare, the simplest thing would be to increase the dose of your medications for a short period of time to control the disease, to remove any triggering factors, which would be avoiding sun exposure, using sunscreen lotions, treating the infections promptly. And if it's a pregnancy which is causing the flare, then we need to take some simple decisions or tough decisions depending on.
Right. Right. So we'll come to pregnancy, because I think that's the next good segue. Just want to let people who are watching know that if you do want any of your questions answered in Hindi, just ask for that, and then we'll answer that in Hindi. Um, Also, we've received a request that my daughter is an SLE patient, and there seems to be ups and downs in urine protein. So whether I should be changing medication, and she's been on this medication since 2014. What would be, he says some nephrologist told him that uh, the medicine should be changed after 2 years or something. What should be the plan of action, or what should be the step that he should take for his daughter?
See, involvement of the kidneys in patients with lupus is a serious complication, which can lead to high blood pressure. It can lead to protein loss, which can cause swelling in the legs, and eventually, if not controlled well, few patients they can even lose their kidney function and go on to dialysis. Now, the problem comes with patients with lupus is that the disease is not going to go away, it's going to stay. So,
Mm,
over time, what I have seen in my practice and other rheumatologists also is that occasionally the medicines that we use to control that aspect of lupus tend to fail. And we call
right.
it secondary failure, where they have worked better in the initial years, but in the later years, the medicine doesn't work that well. So
Mm,
if that's the case, then definitely the treatment has to be changed.
right.
Okay. The second reason occasionally we see is that the patients may not be taking the medications the way it has been prescribed. So if
Mm,
there was a compliance issue, then obviously the disease will not be controlled. The third thing is that for lupus, we have some special medications which are called biologics, rituximab, which is available for a certain category of patients who will benefit from it. So somebody who has kidney problems, which is not responding to usual medications, or some other complications like the loss of blood, where the blood is getting destroyed or platelets are low. These special medicines are useful and they provide good control. Uh, the the care of the patient who has lupus nephritis has to be done by both nephrologist and the rheumatologist, because there are some things the nephrologists are very good at and there
mm,
are some things which the rheumatologists are very good at. If we try to control the disease with one doctor, there will be some lack of care. It won't be complete.
right.
So I think what I would suggest this patient is to probably visit the nephrologist and the rheumatologist again, see the level of the activity, and then plan the treatment.
Treatment. Thank you. Thank you. I think that should answer that question. So let's talk about how lupus affects pregnancy or how pregnancy affects lupus. Um, the first question which we receive very often is, I have lupus, is it safe for me to get pregnant?
Okay. So the straight answer is yes. Okay. But there are some caveats. The first thing I want to share is that lupus does not affect the fertility of the patient. So the disease lupus is not going to affect the chances of a lady becoming pregnant, but it can affect the success of the pregnancy.
Hmm,
So the general dictum or the general rule of the thumb is that the lupus has to be controlled at least 6 months before pregnancy is planned. So there are
right.
patients who just land up in the consultation chamber and say, I'm pregnant, 4 weeks, 6 weeks, now what do I do? That is
Hmm,
absolutely wrong. So the discussion has to be there with the doctor that, okay, we are going to plan pregnancy in the next 6 to 12 months. What are the medications that we need to focus on? What are the aspects that we need to focus on?
right.
So, what I tell my patients is that yes, you can plan, but 6 months your disease has to be quiet. There are certain medications which need to be changed before the pregnancy is planned. So, that will take 3 months to 6 months for a rheumatologist to sort it out. The, the other thing is to look at what is going to happen to the pregnancy. Now, almost 10% of all pregnancies can result in miscarriage.
Hmm,
This number becomes 20% in lupus. A small percentage people have a intrauterine death, or the baby dies after 16 weeks to 34 weeks of pregnancy. Now this number can go up to 4-5% in lupus. Sometimes the patients have the baby is not growing well, or the fetus is not growing well inside the womb, or they may develop some complications like high blood pressure and other things. So these
right.
are the things that we need to talk to them before. Any pregnancy in a patient with lupus is going to be a special pregnancy, which means that it needs special care. Now, I don't want to use the word high risk because it tends to, give this anxiety and worry that, okay, this is going to be trouble for me. But
Hmm,
what I tell my patients is that this is a special pregnancy. You need to take special care. I need to take special care. And the gynecologist who's treating you also needs to take special care.
right. Yeah, so I think that was the next question is, do they need to stay in touch with both the gynecologist and the rheumatologist? And, you already said 6 months before, 6 to 12 months before, they should be having this conversation with the rheumatologist. Do they need to talk to the gynecologist from before, or they can talk to the gynecologist once they get pregnant?
So if the patient is having regular cycles, and they are otherwise well. There is no problems in terms of, let's say, obesity or increased weight or polycystic ovarian disease where there is irregular cycles or some other gynecological issues, then
Right.
it's okay not to contact the gynecologist from before.
Right.
Okay, but if they have any issues like this, where the cycles are irregular, there is some problem during the menstrual bleeding where it's high or low, then it's always good to take their opinion. Now, as a rule, what I tell my patients is that there is no harm in taking a consultation because one, the patient gets introduced to the gynecologist. They assess, are they comfortable with this gynecologist? Are they going to, follow up with them, or there is going to be a change in plan? Second is that the gynecologist may give them some medicines to improve their, fertility or improve their chances of becoming pregnant. There are some medications that we give in the pregnancy planning, like folic acid supplementations, which
Mm.
both me and gynecologists are giving. So
Right.
some minor, points which may affect the successful outcome of the pregnancy can be addressed. During the pregnancy, definitely the gynecologist is probably the number one treating doctor because they are very well versed at looking at the baby's health, the problems which the ladies have. But if there is any medical aspect in terms of blood pressure, in terms of lupus flare,
Mm.
then it's the rheumatologist who comes, in the forefront. But it's always a shared care between the rheumatologist and the gynecologist, and they have to, meet both of them. And the frequency of meeting the gynecologist is obviously more than the rheumatologist.
Right. Right. Yeah. So that was the next question is, some of the risks with pregnancy in any case tend to be things like diabetes, gestational diabetes, hypertension, preeclampsia. Uh, with lupus, are these the ones to watch out for? Are there other complications that people need to anticipate and be prepared for?
Okay. So, in spite of the disease being very well controlled, a small percentage of patients may experience a worsening of their disease during pregnancy.
Mm.
In spite of the best treatment and the best medicines and the best possible care, because some things are not predictable. Now, if the patient has a pre-existing problem because of the kidney issue, they are on hypertensive medicine. Because of the use of steroids, they have developed diabetes. Then obviously this becomes a very, very special pregnancy because we have to look after the diabetes and hypertension as well.
Mm.
Now, during the course of the pregnancy, a small minority of patients may develop high blood pressure and diabetes as well. Now, this can be unrelated to the lupus because now we are seeing people who are becoming pregnant for the first time after the age of 35 years.
Right.
So this, you can call it little bit, older pregnancies, they have
Mm.
more problems of hypertension, diabetes. It's more common than somebody who's 25 or 20 years old.
Right.
So the medications for hypertension, diabetes have to be adjusted such that they are compatible with the fetus and the well-being of the fetus. Preeclampsia or high blood pressure is a normal or not normal, or maybe one of the complications that we see in patients with pregnancy. It happens in patients with lupus as well as normal patients.
Mm.
And it's sometimes very difficult to distinguish the high blood pressure. Is it because of preeclampsia or because of the lupus which is getting flared? So there are
Right.
some clinical clues and some tests that we can rely on. But obviously, uncontrolled hypertension, uncontrolled diabetes, and preeclampsia, they all lead to number one, preterm delivery, where the baby is born by 28, 30 weeks or even earlier. Second is intrauterine growth retardation, where the baby's weight is less, the baby is
Right.
not growing well, and rarely it might end up in the death of the baby. So
Right.
these are the few complications that we don't want the patients to have, and we try to address it.
Right. And if they do, I mean, ideally, if they're managing it well, or if they, they hopefully don't have flares during pregnancy. But do you have, what percentage of cases do tend to have flares, and what are the typical causes, and how is it managed?
So if the patient is well controlled before the pregnancy happened, and they're on minimal medications with no comorbidities of diabetes, hypertension, and things like that. Most of them, a great majority, you can say maybe 80% of them, just sail through their pregnancies, or they have very minor problems. 15 to 20% of the time, they might have some problems like high blood pressure and things like that. And a small minority, 5%, have major complications in spite of being well controlled. Okay.
Right.
The major worry which I kind of focus on is that how to sustain the pregnancy. See, the first 12 weeks of pregnancy are the time where the fetus is very small, it's in the millimeter stage, and that time they can have miscarriage. After 12 weeks, when the fetus needs to grow, at that time they can lose the pregnancy. So in patients with lupus, there is a condition called antiphospholipid antibody syndrome, where they have certain antibodies which are formed in their body, and these antibodies make the blood very sticky, or they make the blood to clot. Now, if the blood clots, what happens? The baby is deriving all the nutrition from the mother. And between the mother and the baby, there is an organ called placenta, which takes the blood from the mother and gives the nutrition to the baby. Now, if the clots are formed in the placenta, then the baby will not get any nutrition. So what will happen to the baby? The baby will either become weak or die, or there will be a miscarriage. So in patients with lupus, we specifically, during the time that we counsel them for pregnancy, we look for these autoantibodies. It's a simple blood test. We do it. So earlier it was kind of thought that maybe if the patient has history of 3 or more miscarriages, then we should do these tests. Sometimes we tend to do these tests if they have a single miscarriage, because patients are also very anxious to have a successful pregnancy. So because it's a simple blood test, I tend to do it because there's no harm. Anyway, they are going to get some other test done, and it's going to change our management. It's going to change the outcome of the patient. So if these patients with lupus have no antibodies of antiphospholipid syndrome, then a simple blood thinner like aspirin, which makes the blood flow easily, is enough for them to go through the pregnancy.
Right.
But if these antibodies are present, or there is a history of miscarriage, or a history of intrauterine death, or some complications in the earlier pregnancy, then we might have to give them, along with aspirin, some injections which are called low molecular weight heparin injections, to make the blood thin so that the blood is not sticky. So depending on the complications that the patient has had in the previous pregnancy, depending on the antibody results, these injections may be given to the patient, and this has to be taken throughout the pregnancy. So the aspirin tablet stops at 34 weeks of pregnancy, but the injections will continue throughout the pregnancy. The other thing that we look at is, if the baby comes early, are we prepared for it? So at the end of 33, 34 weeks, we give an injection of steroid called betamethasone to mature the lung of the baby, so that if the delivery happens at 35, 36 weeks, rather than 37, 38 weeks, the baby is prepared, the lungs are mature, the baby is safe to come out. So these are the few things which the gynecologist and the rheumatologist do as a team to foresee if there are only going to be problems and act accordingly. And for the smooth execution of the pregnancy, give some medication so that the nutrition of the baby is not compromised.
Right. And one question which I'm sure you hear often is, if the mother has lupus, will the child have lupus as well?
I get this question very often. What I tell them is that any disease to develop, it's like a jigsaw, where there are some genes which we inherit from our parents. Do we have any control over it? No. So there's nothing I can do about it, the genes that I got from my parents. The second is, there are some environmental triggers. Now, these environmental triggers could be sun exposure, could be virus infections. Then there are some, personal risk factors. So the commonest is smoking. Smoking is a trigger for many autoimmune diseases, and lupus is no exception. And then fourth is some event or some unknown factor which incites or brings together all these factors.
Right.
Unless all these four things come together, the patient does not develop a disease. Okay. Now, there are some instances where there is a cluster of lupus in family. So the two, sisters are there, both of them have lupus, or the mother has it and the daughter has it. But there are many families in which the mother had lupus, but the daughter didn't have.
Right.
So, unfortunately, at this stage, we cannot do a certain test or a clinical exam or a history taking and tell them, okay, your risk of lupus is this. There is some progress where people have done some genetic studies to look at the risk of developing lupus in future.
Right.
But doing this test, is it going to cause more anxiety or is it going to give me some better results to manage the patient? Nobody knows. That's why they are not become a routine practice.
True.
But my suggestion to the patients who come to me is that if there is a family history of lupus, you know how the symptoms are, you know how the disease is. If you think that you have a doubt that, okay, I'm getting these pains, I'm getting these rashes, I'm having this problem, could it be lupus? It will be worthwhile just to visit the rheumatologist and have a chat.
Right.
We do the test, we do the treatment, that is secondary. But at least that first initiative to meet the rheumatologist will be, better. Will be better.
Right. Right. Another question is, can I
Just,
breastfeed? Sorry.
sorry, there's just one more thing I want to add.
Sure.
Patients with lupus, when they deliver, there are two problems that the lupus can cause to the baby. One is that the baby can have a heart block where the baby's heart rate is low or it's very low. Now that's an emergency, and usually that happens in the 18th week onwards. So in patients with lupus who have a particular antibody called SSA or Rho52, which can cause this problem, we advise that they have a fetal echocardiogram from 18th week onwards to look at the heart of the baby. If that happens, then we have certain medications which we can give. And if it is a complete heart block, then the cardiologist has to do a procedure. So that's a serious problem. The second is in patients who have lupus, when they deliver the baby, occasionally the baby has a rash on the face, on the back, on the chest, which we call as neonatal lupus. Now, why that has happened is when the baby delivers, it has autoantibodies or the normal antibodies from the mother. The mother gives its antibodies to the baby for the first 6 months so that they can fight the infections. So these antibodies also go to the fetus or to the child. Now, thankfully, these antibodies stay in the system only for 3 to 6 months, and neonatal lupus usually resolves in 6 months. So, can my baby have lupus? The answer to that is yes, is a possibility, but there are other factors which come into play, and it's not 100% that the patient or the child is going to have lupus. Second is the patient or the child can have some complications because of the maternal autoantibodies, which can be either transient or serious.
Right. So do you advise that they discuss that with their pediatrician as well?
So once generally any delivery which happens in a patient with lupus, I advise them to do it in a hospital where there is some tertiary care facility available.
Right.
Reason for that is that the complications can happen. The second is the doctors who are working at the tertiary care hospital have some experience in dealing with these patients.
Right.
So they are tuned to what to expect or what not to expect. So definitely in our hospital, I share a very close relationship with a team of gynecologists who generally look after my patient, pediatrician, and myself. So we definitely talk with each other and we look for these problems in the neonate or the child who is born.
Right.
It's just a simple clinical exam where we just need to turn the baby over, look for a rash, and things like that. So definitely a screening is required. And patients, who have a normal, child who is born, the child is should have vaccinations as per the schedule. There's no limitations or changes in that. The vaccinations should proceed.
Okay. one other question is, can I breastfeed my baby if I have lupus?
Okay, so again, the short answer for that is yes. Any patient of lupus, if the disease is well controlled and they are on medications which are safe for breastfeeding. So
Right.
if the dose of steroids is less than 20 milligrams, there's a medication called hydroxychloroquine, or if they are on any blood thinners like aspirin, or they are on medications like tacrolimus, all these patients, it is safe to breastfeed.
Right.
There are some medications which are more powerful, which we need to give these patients to control their disease, like mycophenolate or cyclophosphamide, or if the dose of steroid is more than 20 milligrams or higher, then in that case, we have to maybe stop. If the dose of steroid is more than 20 milligrams and they're taking it in the morning, then they can breastfeed 4 hours after taking the dose. So maybe in that period of time, the artificial milk or some supplementation has to be given to the baby, but the rest of the day, the mother is free to breastfeed.
Right.
Again, these things are usually discussed in the last few weeks of the delivery,
Right.
unless something catastrophic happens or there is unplanned delivery. But from the 28 weeks onwards, uh, me and the gynecologist are kind of counseling the patient regarding breastfeeding and care after delivery.
Right. And you said that there are no issues that lupus patients have as far as fertility is concerned. But if they do have, fertility issues, or they're having challenges conceiving, is it okay for them to use ART assisted reproductive techniques?
Okay, okay. Yes. So, in general, the amount of infertility which is there in the society right now is much more significant than what it was 30 years ago.
Correct.
Now, there are a lot of theories about why that has happened. Is it because of the stressful life that we live in? Is it because of the toxic food that we eat and the toxic environment that we live? Is it because of the lack of exercise or the wrong choices of food? There are a lot of things. It can go on and on. Okay.
Right.
So,
Right.
in patients with lupus who have fertility issues where they have not been able to conceive for a long time, yes, assisted reproductive techniques are useful and they have been tried in lupus patients as well. There is a very small, I won't say it's a very significant, but a small percentage of patients who may develop a flare or a disease worsening because of the hormonal treatment or the various treatment which is given through the assisted reproductive technique. So that
Right.
aspect has to be, borne in mind. The second thing is that, again, when we are going for this assisted reproductive treatment, the medications, are they compatible with the pregnancy and the pre-pregnancy? That has to be seen. Third, the success of IVF, again, does not have a direct relation with lupus. If the lupus is well controlled. So if the lupus is well controlled, patient is on minimal medications, doing well, then that patient should be considered like a normal patient, and the success, the complications, the other aspects of the IVF remain the same. Remain the same. Yeah.
Right. Okay. Um, One question, if the prospective dad has lupus, is there anything that they need to be aware of? Is there any risk of the child getting lupus from the dad, or is there any risk in terms of, does it affect the fertility of the dad?
Okay. Okay. So one thing the men have an advantage is that they don't have to carry the child. So
Correct.
the medications which the man or the male member is taking does not have a direct impact on the growing fetus in the mother's womb. Okay. But obviously, as we discussed earlier, the causes of infertility, especially where the sperm count is reduced, or there are some other problems which are leading to fertility, have risen.
Right.
In male members or in patients, male patients with lupus, if the lupus again does not have any direct effect on the fertility, but there are some medications which they may be on or they might have used in past, which may adversely impact the amount of sperms that they have. Now,
Right.
if that's the case, then the medication can be adjusted. There are some supplements which can be tried to improve that. So, if a couple, either male or female, who has lupus and they have tried for natural pregnancy for 6 months and they are unsuccessful, then definitely I ask them to go for a checkup with the gynecologist. Look at the correctable factors in the in the husband. Look at the correctable factors in the female person, the wife, and then take it from there.
Right.
But males have an advantage that they don't.
They're not carrying the child. Yes.
Yeah, so they can probably take the medications and not worry about complications to the
Right.
baby. Yeah.
Right. We've received a couple of questions. One is somebody's talking about a lupus patient who's been on medications for last 6, 7 years, still has a lot of hair fall. Does hair fall stop? Does it continue? Do they need to relook at the medication?
Okay, so hair loss is a very troublesome symptom. It's not serious, but we are all troubled by it. Even as if you ask me sometimes when I look at my hair loss, I am also troubled. What I had 15 years ago and now is different. And there are a lot of reasons why hair loss happens. Okay, so the simplest reason in a patient with lupus is the hair loss is because of lupus. Patients tend to have loss of hair. The quality of the hair is poor, so the hair is brittle and it breaks very easily. And they can have a certain skin lesion called discoid lupus, which can happen on the scalp, and it can cause contracture or disfiguring of the scalp where the hair loss can be permanent. So they can have patches of rash on the scalp where the hair loss can be permanent. So if
Right.
the disease is causing the hair loss, the answer is control the disease. So that's very simple. But it's not that simple in the practical sometimes because the disease is aggressive. So we have to use certain special medications or topical treatments as advised by gynecologists. Now, there are some other reasons for hair loss, which are different from lupus. The commonest being in women, iron deficiency anemia. So if they have a low hemoglobin, low iron, it causes that. Look at hypothyroidism, if their thyroid dysfunction is there. The third could be something, which is not related to medical, but the quality of the water that they are using or the products that they are using, something like that. So how we tackle hair loss is and also the medications that we use for lupus, like methotrexate or mycophenolate, they can have this side effect of hair loss. So again, if it's the disease, control the disease well. If it's the medication, then either reduce the dose or change it. If it is anemia, hypothyroidism, then look at that. And finally, we will give some nutritional supplements, high protein diet, iron rich diet to look at the hair loss.
Right. Right. One question is because somebody seems to be quite concerned about needing a biopsy. Is a biopsy required in certain cases for lupus patients, possibly with nephritis?
Yes, absolutely. The biopsy actually gives us the direction of treatment. It gives us the amount of damage which has happened in the kidneys, how much of it is correctable, how much of it is not correctable. But before the biopsy is performed, the patient has to be stable. So the hemoglobin has to be optimized, the blood pressure has to be optimized. If the patient has swelling in the legs, swelling in the abdomen, there is free fluid, that has to be controlled. The commonest biopsy that a patient of lupus undergoes is a skin biopsy or a kidney biopsy. And both of them are extremely important in confirming the diagnosis and guiding the treatment.
And it's not just a one time, right? Sometimes the doctor might ask for multiple biopsies, or is that not common?
See, multiple biopsies is uncommon. It's not that every patient of lupus is having multiple biopsies. So in my practice as a rheumatologist in the last 15 years, there are only a handful of patients who've had 2 or more biopsies. Now, when do we do a repeat biopsy? One is when we have a doubt if the kidney problem is because of lupus or something else.
Right.
Now, over the years, when the patients have been on treatment for lupus, they have also become older. The chances of hypertension and diabetes related kidney disease is also there. So to
Right.
differentiate between diabetes, hypertension causing kidney disease or lupus causing kidney disease, a repeat biopsy is needed. Second is when the treatment that we have given for the kidney problem fails.
Hmm.
So are we on the right track? Is there something that has changed from the last time to this time? Then a repeat biopsy is needed. The
Right.
third is if the biopsy which was done on the first instance was poorly performed because of technique, because the sample was not good or the reporting was not good and there is a doubt. Then, so these are the three reasons why a repeat biopsy can be asked.
Right. Okay. Um, I think we've pretty much addressed most questions. Is there anything specifically, doctor, that you would want to, or any words of advice that you would want to give to our listeners?
Sure. I have, probably I would tell my patients a couple of things, which I tell in my clinic as well. The first thing is that if a diagnosis of lupus is made, and the doctor tells you that, okay, this is the diagnosis and this is going to be a long term treatment, we all get upset about it. Why me? Why not somebody else? And how can I take medications for so many years or for the rest of my life? So what I tell them is that why you, the answer nobody knows. But you can take it in a positive way that maybe the supreme or the God wanted to test your patient or your self resolve, or you can say your whatever your strength, and he's testing you through this. So first thing is that we accept, yes, there is a problem. Second thing is that if we treat this disease well, you can have a near normal life. Young women can get their careers on track, they can finish their studies, they can get married, they can have children. If they want to do something, it is possible to be done with the disease along with treatment. Only thing is that there might be a delay in the time. They might lose 1 or 2 years or 6 months of their life trying to control diseases. The third thing is that the compliance to the medications and the visit to the doctor has to be there. So there has to be a good relation established with the doctor. There has to be a supportive family member who they can talk to, and also a supportive friend or somebody who can accompany them for the doctor visit. Sometimes patients are hesitant to ask questions, and the family member takes the lead and asks questions. And I can understand, okay, the patient is not opening up, but this person is helping. The last thing is whatever can harm your disease. So, is it sun exposure? Is it smoking? Is it a lot of emotional stress, irregular eating habits? Those things have to be avoided. You can plan your day such a way that you have some periods of activity where you're doing a good amount of work, and then some period of activity which is less intensive, and some period of rest. So, if we manage our day like this, we can be more productive.
Right.
So, at the end of the day, it's like a shared care where the patient is the first and foremost, and the doctor and the family come second and third. So, if we work as a team, we can definitely, make the patients better.
Right. Thank you. Thank you, Dr. Dugar. I think that was a very, very informative session for people. And we've had a few questions as well from the audience. So thank you to the audience for listening in. And thank you to Biocon for facilitating and supporting this initiative of lupus awareness. So yeah, I think we covered a lot of good ground in terms of how lupus affects young people, and how women, especially who are very concerned about pregnancy or their families are concerned, can handle it, but you need to plan in advance and don't kind of get pregnant and then reach out to your doctor. So I think 6 to 12 months before you plan, you should have this conversation with your rheumatologist. And in terms of treatment, yeah, as doctor said, follow the treatment protocol and work through that. And I think we know, I mean, there are lupus support groups as well now, so you can be in touch with them, or you can also reach out to us. There are people who struggle with the diagnosis or with the treatment and various points, but I think it's one of those things that you'll have to manage. And if you need to reach out to Dr. Dugar, you can reach out through the Apollo Hospital's website as well for setting up appointments. So thank you, Doctor, once again for taking the time on a Sunday evening.
Thank you. My pleasure.